Okay, I think let's go ahead and get going. One thing also just to mention, we've noticed that the number of folks signing in on at least the Monday time frame is kind of falling down. We understand a lot of people getting back into their clinic times. So unless there's a massive groundswell of desire for more talks, we thought we probably would just go to the Friday unknown sessions, which are probably what most people need more anyway than just straight lectures. So probably, I think starting next week, we're just going to mainly go to the Friday session. So if people really want the Monday sessions, let us know. But it seems like that we're kind of getting to the point where it's probably better for people to really get more of an unknown kind of quiz type of session. So I thought I would talk in this session about Spitz's Nevi. It's a very difficult problem in dermatopathology that's been we've had to sort of dealt with for many years. And so I thought it'd be just valuable for you guys to understand a little bit about what the issue is and the history behind it and kind of where we are today as where we were when we first kind of discovered this lesion back in 1948. And this was actually originally described by a pathologist, Sophie Spitz, so the name is named after somebody. And she had noticed that these were lesions that looked like melanoma to the microscope, but didn't behave in a bad way. And so she started calling them benign juvenile melanoma. And she really thought it really was a melanoma, but it just didn't do bad, didn't have a bad outcome. She unfortunately died of ovarian cancer, I believe, in 1956, before the term even actually got accepted. So she never knew that this lesion was named after her. And here's a picture of her back in 1932, and she actually practiced up in New York at Memorial, Sloan Kettering, up in that area. And this was the original paper, and she called it Melanomas of Childhood. And again, she was really looking at these lesions that today we know are benign. So what is a Spitz's nevus? I want to define it. There's a lot of different variants of it, but basically it is a benign lesion. It has all the features of a benign process architecturally. Cytologically is where it sometimes gets tough because we can see some mitotic figures, pagetoid spread, some prominent, really severe cytologic atypia. So it's kind of an interesting lesion in that it breaks the rules. So it looks benign clinically, looks benign under the microscope from an architectural perspective, but cytologically it can simulate melanoma. And so that's one of the reasons that there's the difficulty in making the diagnosis over the years. And then we see dull pink globules in the epidermis commonly, epidermal hyperplasia, hyperkeratosis, hypergranulosis. So just our general my general impression, Spitz's nevi, they're not super uncommon. People say, well, gosh, I hardly ever see them. Well, we see it histologically in the microscope, at least a couple of 3 a day, I would say. And when you count up our consultations, we see Spitzoid features in dysplastic nevi and other lesions too that we report sometimes. They are seen most commonly in kids, but up to 40% are seen in adults, especially young to middle-aged women. And of course, we know that they're simulators of melanoma. And so, you can't just call everything an atypical Spitzoid melanocytic lesion and hedge everything. That doesn't really work too terribly well either. You really need to use criteria to be able to make the diagnosis. And most of the time you can. It's these sort of borderline areas that sometimes it can be kind of difficult. Now, there are a lot of different clinical variants. And in the last probably 8 years or so, there have been a lot of the molecular pathologists, dermatopathologists that have started looking at the genetics of Spitz's nevi. I don't think I have too much in this talk about that, but that's kind of an interesting finding also. So if they look one way under the microscope and clinically, they have genetic features that kind of correlate with that. And so these are some of the clinical variants. And this is an example of one, a little small dome-shaped papule. Clinically, we probably think of this as intradermal nevus, but when it was biopsied, it showed the Spitz's nevus. Another example here. These are obviously in kids. The ear. So they sometimes have kind of an orangish color. When you feel them, they feel a little bit firmer than a classic intradermal nevus sometimes. Orange is a color we often see in these lesions, like here. Here's one that had a little brownish color to it, dome-shaped papule. And then there's the so-called pigmented spindle cell tumor of Reed that can be really jet black, and that can simulate melanoma clinically sometimes. They can be agglutinated in a group like this, like a cluster, almost kind of like an epidermal nevus in a way. It's clustered like that. This kid had a widespread systematized form of Spitz's nevi, had hundreds of them all over his entire body. Here he was when he was a little bit younger. And I think there was a paper published, this is the same kid, and I think there was a paper published maybe 10 or 12 years ago when he was an adult, and he still had all these lesions. Many of them had kind of turned into intradermal nevi over the course of time, and he never got a melanoma. Did fine. So there's a number of histologic variants also. I'm going to go through some of these for you as well. So junctional Spitz, spindle cell predominant. So here's a clinical of one of those. So again, shave biopsy, dome-shaped papule. It's got mostly spindle cells. So that's one variant of a Spitz's nevus with abundant melanin. So that's kind of almost like a spindle cell tumor of Reed. Camino bodies over here in this area. And again, so totally benign. We wouldn't hedge this. We wouldn't call it atypical Spitzoid melanocytic lesion. We wouldn't send it off to Myriad. We wouldn't do anything. We would call this a Spitz's nevus and move on. Sometimes you get more of an epithelioid component. Again, clinically benign. Cells they look more epithelioid this time as opposed to spindle. And this one's got some pagetoid spread. And that we see that commonly in Spitz's nevi. Notice the cluster of camino bodies. And one thing that is helpful, if you see lots of camino bodies in a Spitzoid lesion, it's almost always Spitz's nevus. You can sometimes see some melanomas and Spitzoid melanomas, maybe a couple of caminos, but even there it's pretty rare. Usually you just don't see camino bodies in true melanomas. But if you see a lot of camino bodies, that really favors the Spitz's nevus. It's not a diagnostic feature of Spitz's nevus, but it's a helpful finding. And here's a mitotic figure, and they can be very atypical mitoses. They don't have to be bipolar. They can be bizarre, weird mitoses, still benign. And you can get pagetoid spread. So again, this is one of the situations where sometimes the clinical and the histology, there can be some confusing features. Acral Spitz's nevi. Here's another one on somebody's hand. And again, this one's got more of a verrucous epithelial component associated with it. Mostly nested, mostly epithelioid cells, a little bit of pagetoid spread. Okay, but not a lot of pagetoid spread. And here you see the characteristic epithelioid cells. So that was a totally benign lesion also. Here's one that's got both a spindle and epithelioid variant to it. Okay, shave biopsy. Of course, obviously we like to get, especially in some of these Spitzoid lesions, we like to see the entire thing if possible, or at least a saucerization lets us look at the edges of it because we really like to apply the architectural criteria as well. But even in this shave biopsy, you can see it's mostly nested, mostly at the junction, mostly epithelioid cells here. Again, you may get a mitotic figure or two in this lesion. This came from an 8-year-old girl. And so my general rule of thumb, and there's a mitotic figure, not a lot of them, just one or two, that in a child, for it to be a melanoma, it's really got to be perfect for a melanoma. It can't have 75% of the features of a Spitz's nevus and maybe just a little asymmetry, and then you say, it's atypical Spitzoid, possibly melanoma. No, it's got to pretty much have every feature of melanoma in a kid for it to really be a true melanoma versus a Spitz's nevus. So here's one of these acral, heavily pigmented lesions, might be kind of a spindle cell tumor of Reed. And here we see at high magnification, very heavily pigmented lesion with these spindle and epithelioid cells here. Again, this one does not have any pagetoid spread. This one did not have any mitotic figures. So again, even though it's heavily pigmented, it's still a Spitz's nevus. So we wouldn't worry about this. We wouldn't hedge it. We wouldn't call it anything to be too worried about. This was an older person. Again, a dome-shaped skin-colored papule. Shave biopsy. They weren't worried about melanoma at all here. And it shows mostly the spindle and epithelioid cells in the dermis here with no epidermal involvement, no pagetoid spread, no camino bodies. So this is just yet another variant of a Spitz's nevus, and this was in an adult. And 40% of Spitz's nevi are seen in adults. I've diagnosed Spitz's nevi in people that are 80 years old. And not too commonly, but I have done that.
So again, just realize that Spitz Nevi, there's no reason they can't occur in adults too, if they maybe have been there for many years. It just happened to be present when they're biopsied when they're an adult. So let's talk a little bit more about pigmented spindle cell tumor of Reed, named after Richard Reed, who's a dermatopathologist that practiced in New Orleans for many years. And basically these lesions, I think I've already showed you a couple of clinicals. They tend to be small, they tend to be heavily pigmented, and they tend to have more spindle cells than the epithelioid cells. So here's an example of one of these. This one's got, spindle cells predominantly, a little bit of epithelioid cells too, but this one could fall into the category of a pigmented spindle cell tumor of Reed. Usually they're a little bit more heavily pigmented than this. Sometimes we see features of like an obvious, like an intradermal nevus or a compound nevus, and then we see areas of Spitz Nevi within it. And these we sometimes refer to as combined Spitz Nevi. So clinically, they don't look any different than other Spitz Nevi. And so here's one that's got kind of looks like a features of a congenital nevus in the dermis. And you go to higher magnification. Over this other area, you've got more epithelioid and spindle cells. So this part looks like a Spitz Nevi. The other area looks more like a congenital nevus. So we call it a combined Spitz Nevi in that situation. Sometimes we see a very sclerotic stroma. And here we refer to this as a desmoplastic Spitz Nevi. And these are usually more in the dermis as opposed to dermis and epidermis, and they usually have been present for a long period of time. So again, another example clinically. And this is a punch biopsy of a dermal desmoplastic Spitz Nevi. Nothing in the epidermis, maybe a little bit over here, but mostly in the dermis. And you've got this sclerotic desmoplastic stroma with these cells that are epithelioid, some arranged in nests, present diffusely between and among those collagen bundles. So again, that was a benign nevus. It was in a child having a desmoplastic morphology. Sometimes we see Spitz Nevi where the cells are very discohesive under the microscope. And sometimes these get submitted as rouleau pyogenic granuloma. And when you go to these under the microscope, so here's another one of these orange Spitz Nevi, might have looked like this. And you've got this verrucous epithelial hyperplasia, and you've got these discohesive cells. And this is the one that I believe has been associated with the 11 chromosome abnormality. So Boris Bastian and some of his coworkers have looked at these lesions under the microscope, they're genetically, but correlating the microscopic and the clinical together. And they found some of these interesting genetic correlates that go along with some of these lesions. So if you get some of these unusual warty features with some of the verrucous changes, those often look like some of these 11 chromosome abnormalities. There's also been some fusions, gene fusions associated with Spitz Nevi. So there are a number of these genetic correlates now that seem to go along with these variants that we see clinically and histologically. This is still a benign process, not something that we would call melanoma. We wouldn't really even call this an atypical Spitzoid lesion. We realize it's just one variant of Spitz Nevi. Now, you may have heard the term Spitzoid and Spitzian. Sometimes you'll get a pathology report back from a dermatopathologist that says it's a Spitzoid lesion or a Spitzian feature, something like that. And what that basically means is that it's got some histologic features that look like a Spitz Nevi, but not enough for just a classic Spitz Nevi. So maybe we see a dysplastic nevus, for example, with some epithelioid cells or something like that, and we basically say it looks as some Spitzoid features. And sometimes we see a melanoma, really and truly think it's a melanoma, and it's got some spindle cell and epithelioid cell features, and then we say, well, that's probably a Spitzian or Spitzoid malignant melanoma. And I recommend using this term with care. Don't overuse the term. Clinicians get freaked out when they see it. They think, oh my goodness, this is maybe a melanoma, and they excise it, and it's often something that may be more interesting to the histologist, but it's not really that important from a clinical perspective. So this looks like a dysplastic nevus, and this was a biopsy that's got features that look like a dysplastic nevus, but it's also got some cells that are a little bit more heavily pigmented, and they're a little bit spindle cells, so it's got a little bit of a pigmented spindle cell tumor of Reed component to it. So this might have been called a dysplastic nevus with features of Spitz Nevi in a way.
And all this melanin being transepidermally eliminated doesn't mean that it's a melanoma. Basically, it was just an example of a dysplastic nevus with some Spitzoid features. Sometimes this actually in the literature has been written up and referred to as a spark nevus. I think out of Yale a few years ago, they wrote this paper up. It's quite nice, nicely done, which showed what we see histologically, that lesions look pretty classically like a dysplastic nevus. And then you biopsy them, and then they show these features of both Spitz Nevi and dysplastic nevi. So they called it a spark nevus, Spitz nevus with features of Clark. Now, these are some of the clinical pathologic genetic variants that we've seen, and you probably have all heard of the BAP1 mutated nevi. These are often seen in lesions that have a Spitzoid morphology to them. So they look like a Spitz nevus, but they have these very large cells, and then when you do this stain for BAP1, it's lost. And you know, this mutation is this BAP1 is in the 3p21 area, and that's been associated with uveal melanoma. And most of these lesions that have this mutation are benign. They're not cancer, but it's a little bit of a red flag. You know, it indicates that there's at least some mutation there that's associated with melanoma. So if we see this, we often may recommend conservative removal. But this is a lesion that is sort of a kind of a histologic curiosity. So these lesions clinically look more like Spitz Nevi. They're these orange dome-shaped papules. You do a biopsy, they show features of the nevus, but then these large cells within them. And sometimes those cells are very large, like here, multinucleated with these large, somewhat pleomorphic nuclei in there, but no mitotic figures, no striking atypicality. And you don't want to overcall this a melanoma. Just realize that it's a histologic variant, and if you stain this, it'll show loss of the BAP1 expression. So it's almost kind of like a muratori, where you're looking for loss of the expression. This sclerosing Spitz nevus, I mentioned this before. These lesions tend to have more of the desmoplastic morphology. They're pretty large. They have this 11p gain with or without an HRAS mutation. So you see this under the microscope, it kind of looks like a desmoplastic Spitz nevus. You can probably say, you know, that's going to possibly have an 11p chromosome abnormality associated with it, and you can see that with the fish right there. But this looks kind of like some of the lesions I've showed you before. And you see these sometimes these Spitz nevi that have these ALK fusion associated with them. And so, you know, gene fusions, you all know what those are. It's where one piece of the chromosome kind of breaks apart and gets sort of welded to another one. And then basically you get sort of an increase or decrease in expression of genes associated with that. These are often associated with activation of proto-oncogenes. So even though these are benign lesions, these have these interesting sort of plexiform morphologies to them, and they tend to be polypoid. So if one looks kind of like a wart, like this one, these are often going to have this ALK fusion associated with it. So you see a little kiddo's got a wart-like lesion, you biopsy, send it in as a wart, comes back with Spitz nevus with epidermal hyperplasia. It's probably going to have an ALK fusion associated with it. Now, where this really gets sort of more clinically relevant is when we need to make the differential diagnosis between a Spitz nevus and a malignant melanoma, because again, sometimes these can have features that can simulate one another. The pagetoid spread, the mitoses. And you know, some melanomas can be Spitzoid in morphology. Most of them are not, but some of them can be. And so obviously, you know, our number one concern is that we don't want to undercall something that's a melanoma as a Spitz nevus and then nobody does anything about it. That obviously leads to a bad outcome. But that's not always the case. You can't always just call everything an atypical Spitzoid melanocytic lesion, recommend excision, and yada, yada, yada. You sort of have to, you can cause problems in that situation also. There's a very famous case of a woman who had a Spitz nevus that was called a Spitzoid melanoma. She was pregnant at the time and had the lesion excised, sent a look at a biopsy, didn't have anything wrong. But because of the concern of the pregnancy causing the melanoma to behave more aggressively, she had a therapeutic abortion. And when it was reviewed after the fact, it was downgraded to a Spitz nevus. Well, obviously that wasn't a good situation, and there was a lawsuit over that a few years ago. So you can't got to be like the three bears. You can't be too hot, too cold. You need to be just right on these lesions. So what are some of the features that favor Spitz? Well, obviously symmetry, aminobodies, maturation, multinucleate epithelioid cells. Those are most commonly seen in the Spitz nevus. In melanoma, we look for asymmetry. We see, if you ever see necrosis on moss, it's not a Spitz nevus. I don't care what. I mean, that's almost never seen in a benign melanocytic lesion. So that's really a red flag if that's present. The Spitzoid melanomas usually have a broad base to them, broad bottom, whereas Spitz Nevi, if they're deep, they often kind of have a wedge shape to them. If you get mitoses near the bottom or heavy melanin pigment near the bottom, those are things that favor Spitzoid melanoma. So sometimes they can still be just tough to diagnose. This was a 13-year-old kid, had an atypical Spitzoid lesion. We favored a Spitz nevus in this. It was a big lesion, had a broad bottom to it. Cells were pretty large, pretty atypical. You know, we still thought this was probably a Spitz nevus, but this wasn't one we just were 100% sure of. You know, we recommended excision. And this is the type of lesion that today we would definitely think about using FISH or a genetic test to help us in something like this. So when I first started training with any of this stuff, and now over the last 5 to 7 years, we've got these tests now available to us that in an equivocal lesion, a tough lesion, we can submit it for this and then see what it's going to show, and that's very helpful. So it's got these large cells, multinucleated. It's probably a Spitz, but it's got some conflicting criteria. And so that really strongly favors melanoma because it's probably got about 80% of, or Spitz nevus rather, because about 80% of the features of Spitz nevus, just a few that favor melanoma, but still, we wouldn't just leave this lesion alone. We definitely wanted it completely excised here. And it was excised, and there was never any metastasis, and the kid did well. Okay, so here's another one, 35-year-old. So now we're not in the childhood category anymore. And this one's more atypical. It's a shaved biopsy, so unfortunately that hamstrings us a little bit with regard to looking at architecture. But you can see it's a little bit asymmetrical. It's a bit denser on this side than this side over here. We go to higher magnification. It's got mostly nests of cells. There's some pagetoid spread, but not of single melanocytes. And here some of these nests are larger, and they tend to coalesce. So here, I would be far more concerned about the diagnosis of a Spitzoid melanoma. And in fact, in this case, we call it a malignant melanoma, but it's got some Spitzoid features to it. So here, an adult, it's got to look perfectly like a Spitz nevus. No asymmetry, no irregular sheets of cells that are coalescing like here. Nothing like that. If you see that in an adult, it's a melanoma. Here's another area. This one did have some more irregular melanin distribution and more single cells throughout the epidermis. So this was a Spitzoid melanoma in an adult. But you can see it's got some Spitzoid features. So if you just had a small shave of one of those areas, you might not be able to tell for sure whether you're dealing with a Spitz nevus or melanoma. So that's one of the reasons why we need a good saucerization biopsy that allows us to be able to assess breadth, symmetry, circumscription, and some of those features. So rule of thumb, in an adult, it needs to be perfect for a Spitz, or it's more likely to be a melanoma. In a kid, it needs to be perfect for a melanoma, or it's more likely to be a Spitz nevus. You know, so in some case, we're not sure. We recommend removal, and that's where we can also use some of the new genetic testing available to us, which is really very, very helpful and welcome. And we're glad that it's available to us today. So what are some of the techniques that are used? Well, a lot of people use immunoperoxidase staining. I'm not a big fan of that. I'd rather just use more of an objective test. So we use a genetic test, but some people look at staining, HMB45 and MIB1. HMB45 tends to be more diffuse in melanoma and less diffuse in the Spitz nevus, but that's a subjective finding. And I wouldn't hang my hat on that alone, so I don't use it. If I can't hang my hat on it, I think it's a waste of money, so I don't use it. Some people use Ki67 or MIB1 looking for the mitoses and the proliferation. That's a little better. But once again, Spitz nevi tend to have mitoses, so you're going to see it. So that, to me, it's just not that helpful. So this was melanoma and a diffuse HMB45 expression, but, you know, and here's a case at Ki67 staining an evoid melanoma. Okay, great. You know, you could probably see the mitoses. P53, This is supposedly more positively present in melanoma versus Spitz Nevi, but again, I find this to be somewhat spotty. So this area, yeah, it's really heavily expressed here, but not so much over here. Is this benign and this is malignant? You know, I don't know. I don't use that stain much. I like this loss of P16 a little bit better. It's a tumor suppressor gene, so you think it should be expressed in a benign process and then lost in melanoma. But, you know, sometimes we see it lost in nevi as well sometimes, just for one reason or another. So I don't use this technique as much personally. When it's present, it's so obvious, you can kind of make the diagnosis anyway. So here, even though it's not even an H&E, you can see it's an obvious sheets of melanoma here. So sure, you're gonna have loss of P16 in that. It's in the situation where it's this atypical Spitzoid lesion and you get a little bit of loss of P16 that you're really not sure what to deal with. In the old days, we used to recommend taking out the sentinel lymph node. So before we had genetic testing, we were saying, hey, cut the lesion out, take out the lymph node. If it's got lots of atypical cells in there, then just upgrade the lesion to diagnose to melanoma. But today, we know that sometimes Spitz Nevi can spread to one lymph node and never kill the patient. So, so that's not probably a good idea today in most cases. We don't really do that anymore. So here's an example, 13-year-old boy had a atypical Spitzoid lesion. We thought it was probably a compound Spitz Nevi, but he had some features that under the immunohistochemistry we thought to be melanoma. Got completely excised. A sentinel lymph node biopsy was performed. So here's his lesion. This was actually biopsied before we had the genetic test or we had FISH. So this is an older case, but basically he just simply had this lesion excised. It's got lots of atypical areas in it. It's kind of got the sheet-like growth pattern. It's got a mitotic figure in there, as you can see, not an atypical one, a lot of pleomorphic cells. So this was a tough case, and we didn't have genetic tests back then, so we just recommended excision. So the lymph node biopsy was negative, and he's lived happily ever after in spite of that. Now, that doesn't mean it's not a Spitzoid melanoma. This was his Ki67 stain, which is strongly positive in many of the cells, but he had mitotic figures. This was his P53, which highlighted a lot of the cells also, but he's done fine ever since that time. So again, that's one of the reasons that I'm not the hugest fan of those stains, because I just don't like them as well. I'd rather get something that back that's objective, that I don't have to count cell staining. I don't have to look at an area and see if the staining is more strongly positive in one area than another. So if you look at Spitzoid lesions, they tend to have fewer BRAF or NRAS mutations, whereas melanoma we know is a BRAF mutation. You tend to get HRAS mutations here a little bit more commonly. And then, of course, fluorescence in situ hybridization. We're looking at specific areas within the genome where melanocytes tend to be mutated, and we get the one that we get most concerned about is 9p21. Homozygous deletion of 9p21, and it's not really 21, it's 21, is actually a red flag. Even in a kid, if we see this, we tend to be worried about it because that tends to be associated with bad biological behavior. So how does this FISH work? Well, again, it's not a totally objective test. You do the biopsy, you get the actual tissue, you actually take these fluorescently labeled oligonucleotide probes. It goes and binds to areas within the cells of interest, and then you look at these little dots under a fluorescence microscope. And the way this is generally done in the laboratory is that a technician screens that first, and then they give it to the pathologist. Well, anytime a technician screens, there's a potential for error. So that's one of the reasons I don't like this technique as well as the genetic technique. So here's some examples, all these beautiful little red and yellow dots, and get too many of them or too few of them. It's associated with the aberrant aneuploidy. So again, we're really looking for this homozygous 9p21 deletion. And this paper was published a few years ago, American Journal of Surgical Pathology. This doesn't look like the world's most classic Spitz Nevi here. It's a large, broad lesion that's kind of crusted. It's got a broad bottom to it. It's ulcerated, sheet-like growth stage. It was a young kid, 8-year-old, but it really looks like an atypical lesion. So this has got almost all the features of melanoma clinically and histologically. And it actually did have the 9p21 deletion there, homozygous. And that kid actually did get metastases of his lesion. So that was an example where it helped. I do some consulting for Myriad, so that's a disclosure, but I like this test. And when it first came out of the market, I wasn't a consultant for them. Once it became available to us, we started using it because we said, hey, this is a good genetic test we can use. It gives us an objective result. It's looking at 23 different genes, and one of them is PRAME. It's got another S100 protein gene that's looked at, and it actually gives a melanoma diagnostic score. And so when you get the results back, it gives you something like this, either benign or malignant or indeterminate. And the indeterminate, about 10% of the time is the time that you get the indeterminate result. And obviously when you get an indeterminate result, it's usually one of these cases that's an indeterminate lesion. So it doesn't always help you, but just like every test, you're not going to get a perfect 100% black or white result every time, but it's very helpful when you get a tough case like this. So just remember the Goldilocks rule for these melanoma kind of lesions. And so how do you deal with these sort of atypical Spitzoid lesion in kids? Well, this paper published by Larry Eichenfeld and Sheila Friedlander, the really well-known pediatric dermatologist, they talk about using these techniques and how to go through and use these if they're these atypical Spitzoid lesions. So use these techniques in an algorithmic method. And so we're using these more and more, and it's really, really helpful to get one of these that's sort of atypical and it comes back as strongly benign. And usually Spitz Nevi will give you a strongly benign result, usually -6, 7, or 8 on the Myriad score. Now, what if you get a sentinel biopsy in a patient with one of these atypical Spitzoid lesions? What do you do then? Well, the good news is it's not always a death sentence. When I was trained by Dr. Ackerman years ago, he used to say that if a melanocytic lesion goes to a lymph node, the patient's dead, they may as well go write their will up. Well, we know now that's not true. There are a number of situations where there have been good papers, like this one, where patients have Spitzoid lesions and they spread to one or a few lymph nodes in the regional area, and they can live for many years, never going further than that. So it's not always true that when a melanocytic lesion spreads to a lymph node that it means they're going to die from it. So we used to think that, but today we don't. So that's a good thing about these Spitzoid lesions is sometimes when they do go to a lymph node, even if they're atypical, they get called Spitzoid melanoma. The patient may not do as bad. And so if I get one of these very atypical lesions, maybe we've worked it up genetically, maybe it comes back as indeterminate, I'm not calling them Spitzoid melanomas today, especially in a kid. What I'll often do is call it an atypical Spitzoid melanocytic lesion with a note that says that many of these lesions may spread to 1 or 2 regional nodes, but the patient doesn't have a bad biologic behavior in many cases. So we're learning from these lesions. They're teaching us this stuff now. And so maybe Sophie Spitz was right. You know, maybe these are benign juvenile melanomas. Maybe they're not always really malignant in every case. So when you get a bad biopsy, things just get, it's just like, you know, multiplying it times 10, you know. So here's an example. I like to show this case. I've shown it probably hundreds of times. It's a shaved biopsy from a middle-aged woman. And you can see we don't know the breadth, the symmetry, the circumscription. It looks small based on this, but it does go to both edges. It's got the spindle and epithelioid cells arranged mostly in nests. There's epidermal hyperplasia, there's hyperkeratosis, hypergranulosis. There are really no mitotic figures here. It's got the little pagetoid cells above the junction like we see in Spitz Nevis. So this lesion was called a Spitz Nevis. It was a youngish woman in her 20s. It wasn't called melanoma. Nothing else was done. They didn't re-excise it. Here's another young woman in her 20s. Different patient, but looks pretty much the same. Shaved biopsy, epidermal hyperplasia, nest of cells, epithelioid, and this one was called a melanoma. This one was diagnosed as melanoma, and she had it excised, and she lived happily ever after. Well, the first lesion about a year later recurred, and they took a deep saucerization biopsy, and guess what? It's an obvious, ugly, characteristic, typical melanoma now. So it was called a Spitz Nevi, nothing was done, and now it's an obvious melanoma. And so that's the kind of problem that we've had to deal with over the years, that now we have these techniques that allow us on a shaved biopsy like that to do these tests, so we don't have to call it an atypical Spitzoid lesion or call it a Spitz Nevi and it's underdiagnosed and then a lawsuit develops. So here we have a patient, it's a true story here, and this did happen in developing a lawsuit. I went to a family physician. He would then see a brochure at his work about melanoma, and I went to the physician, diagnosed it as a benign lesion. They excised, they took a biopsy of it anyway, so they did a deep excisional biopsy, as you can see here, saucerization type biopsy. It shows this dome-shaped papular lesion, and in this area, it looks like a pretty obvious nevus, but it's got a few abnormal cells at the junction and slightly above it, which is a little bit of a red flag. And then in this other area, the cells were a little bit more epithelioid. It's a little different. So there's some asymmetry here. Okay, so it doesn't look perfect for just a regular garden variety nevus. There's something going on here. And there's another area. And some of these cells are larger, epithelioid. So is it a weird combined nevus? Is it an unusual Spitzoid melanoma? What's going on here? Well, there was a sign out, it was signed as like an atypical Spitz Nevi. They didn't send it out for consultation. They basically didn't recommend anything else be done. And the patient got a lymph node met 16 months later. And then he got sent to a large referral center for skin cancer treatment, and they called it a melanoma. Well, the consultant dermatologist, and I actually looked at it too, I said it was a tough case. It was ultimately called Spitzoid melanoma, but it was a difficult case, and it eventually settled out of court. So just realize that sometimes these things still are tough, and sometimes we have, good news is we have these techniques available to us to kind of help us make diagnoses. So that's, in a nutshell, the issue with Spitz Nevi and Spitzoid melanoma. Most of the time, they're not that difficult to diagnose if they're seen in children and they've got these characteristic features. But just realize that there are situations where they can be tough to diagnose, and now we have genetic tests available to us. We even have prognostic melanocytic tests, the Castle test that we can use if we think it's a melanoma. So that's helpful to us as well. And there will be more and more of these techniques coming down the pike that are going to be available to us coming forward. So I think that's probably more Spitz Nevi than you've ever seen in your life, which is a good thing. So hopefully you'll remember most of them are benign, most of them are in children, most of them it's not a tough situation, but it can be an occasion. And the good news is now we have these techniques available to help us. So with that, I think we'll close it down.